Good evening, ladies and gentlemen. Greetings from Team DentistChannel.Online. A warm welcome to each and every one of you attending this live webinar. It is my privilege to welcome the very cool, the very charming, and a very down-to-earth personality, Dr. Hemang Zala. Dr. Hemang completed his graduation from the Government Dental College in Jamnagar and later went on to pursue his master's from CDSR Ahmedabad, Gujarat. Dr. Hemang has over 20 years of clinical experience in dentistry and currently runs a private practice in Ahmedabad, Gujarat. Over the years, Dr. Hemang has mastered the art and science of oral implantology and has received extensive training from Bangkok, Thailand, London, Boston, Singapore, California, Croatia, Vienna, and Rome. He has also contributed enormous work in research and has placed numerous short implants successfully in his practice. He has also conducted and organized various hands on training sessions and live surgeries to further impart his expertise. He has a passion for simplifying difficult subjects and concepts and has been a clinical advisor to world renowned implant companies. Dr. Hemang certainly is a down to earth personality. He is the implantologist you can reach out to in the middle of the night. Dr. Hemang is just one call away. Thank you so much for joining us for this live webinar, Dr. Hemang, and now request you to kindly continue with the live webinar.
Thank you, Ruben, for your generous introduction. Welcome all. Good evening. I would like to introduce myself as a clinician and not an academician. So expect less statistics and data and all that slides. I know most of you are fed up with webinars, web series, Corona updates. So I'll keep this presentation short, simple, and specifically for implant abutment connection. So without wasting time, let's go ahead. The content of my presentation would be introduction, so that all of us are at the same plane. Type of connection, discuss about different internal implant connection, microgap, mechanical and biological complications, and clinical implication, and then conclusion. So introduction, two-piece implants are typically composed of fixture, abutment, and retaining prosthetic screw. So here we are not talking anything about single piece implant. So we are excluding that single piece implant from our topic. It's just for two piece implants, and so there is no talk about one piece implant. They are great, whatever the reason is, but we are just focusing today on two piece implant. The two piece implant, we can say it has two parts: the fixture, which sorry, the fixture which is supposed to be there in the bone, the abutment which is supposed to the prosthetic part, and the retaining or prosthetic screw. So the location where implant and abutment are connected is called implant abutment interface. The implant abutment connection is crucial synapse between the implant and abutment and responsible for transmitting occlusal forces from prosthesis down the implant fixture. So we know that all the forces which are generated from the prosthesis will go down to implant with this interface. The different connection geometry structure will lead to different mechanical performance. So broadly, we can classify implant abutment connection in two parts. It's external connection and internal connection. External connection, a connection that extends superior to the coronal portion of the implant. Can you see this? The connection is extending superior to the implant. And the internal connection, the connection that extends inferior to the coronal portion of the implant and is located in the inside the body of the implant. The external connection is nowadays not so much in use, and it was original Brennermark two-piece implant connection. But with evolution, now the companies all have started more using towards the internal connection. So again, we are excluding the external connection from our topic today. We are focused on internal connection. Okay? So with the evolution of internal connection, implant companies have developed their own designs, So what has happened that there are so many implant companies, and each implant company has their own designs of internal connection, which may be two or three different designs, and which has created so much confusion regarding terminology and type of connection. So to simplify, I have grouped this all connection in three different uh, groups. So I'd like to share something over here that I have made certain classification diagrams, charts, groups which are not there in the literature, but it's easier for you to understand. So if you consider any of the implant company which you are using or it's available in the market, you can put in any one of these three groups, which are distinctly different from one another. They have different characters, which we'll see one by one, right? So we can start with the first, the slip fit or butt joint. The butt joint or slip fit connection characterized by slip fit joint, which has slight space existing between the mating parts and the connection is passive. So there is a micro gap between the implant and the abutment. So you can place the abutment properly, sit the abutment properly on the implant. The joint surface also incorporate anti-rotational and indexing features. So because there is a micro gap, there is always chance to rotate the abutment over the implant. So there has to be a geometrical structure, parallel wall geometrical structure, which will avoid the rotation of the abutment. For that, the different geometries are included, which can be a trichannel, octagonal, hexagonal. There might be more. So again, we'll just go through it. So we have a butt joint or slip fit connection where we have hexagonal, octagonal, trichannel. I'll quickly tell about this also. Internal hexagonal, we normally call it internal hex. It has six different sides, and you can adjust your abutment at six different positions. And it is one of the most widely used right now by almost all implant companies. The second one is trigonal or internal tripod, where you can place your abutment in three different directions at 120-degree position. You have to be careful that this point is towards the buckle so that you have more, don't have to face more challenges during the process if you are using especially the angulated abutment. Octagonal, it has eight sides and you can place abutment in almost eight different positions at 45-degree interval. So how do you achieve the assembly? Means how do you fix the abutment on the implant? So first of all, you select your abutment depending on the tissue thickness and the emergence profile, right? You place the abutment on the implant. You engage the internal hex. Suppose if you're using internal hex properly to the implant corresponding bed. Then with the help of hand screw hex, you just put the screw, tighten it up, check all whether there is any interference with the abutment, check everything well. If you feel that abutment has properly seated on the implant, at this point you take the X-ray. It's very important to take the X-ray. You check with the X-ray, and if you are satisfied with the X-ray, then you take your torque ratchet, and according to company's recommendation, you torque the screw, say it's 30, then you wait for 4 to 5 minutes, and then again retorque it well. So this is how you secure your assembly with this type of connection. The screw should be tense to produce a clamping force greater than the external force tending to separate the joint, which normally your company will recommend. So due to the micro gap which is present, it's a passive fit. You know, the implant and abutment are passive fit. There is a micro gap. The screw will only hold the implant and abutment in the place. So due to the inherent design of this passive fit between implant and abutment, there exists a micro gap, or we can call clearance fit, which is normally not visible in our radiograph, but it's visible in this high magnification photograph. The average micro gap of implant and abutment junction has been reported from 1 to 14 microns. Right? So we'll come to this micro gap portion a little later. So now we'll switch to our another group, which is self-holding taper. Now this self-holding taper and self-releasing taper are not terms which are used in dentistry. I have gone through literature of engineering and where I have find this self-folding taper and self-releasing taper. So why I have used this over here? I'll just tell you. So what has happened that in implant market, every company comes with us and says that they have a conical connection, which they call is a Morse taper. So are all conical connections in dentistry Morse taper? So the answer is no. So if we see this classification for machine tapers, they have distinct two different types, self-folding taper and self-releasing taper. The taper which are not self-folding can fall under this self-releasing tapers. So what are self-folding tapers? For the clarity point of view, we can say that self-folding taper over here is Morse taper connection because we are used to this word, Morse taper connection. Self-releasing taper are all other conical connection, which we'll see later on the second part. So what is Morse taper? An American scientist who invented an engineering marvel called Morse taper in year 1864. So it's almost 160 years ago. This this physics engineering marvel was being invented, and it's still most widely used in all engineering parts. So Morse taper is a cone within a cone. When two perfectly manufactured cones are tightly brought together, they provide a well or friction lock stability. Right? Because of this high locking stability, they are used in engineering wherever they have high axial or lateral load with or without vibrations. The range of machine tools, pulleys, bulk carriers, aircraft, we can say orthopedic knee replacement, the Formula One cars where the wheels are fixed with the most stable connection where there is high demand of joint stability. So all that places most taper are being used. So what is the most taper which makes it different from the other tapers? So we go through uh, these three parameters, which are very important for the taper to be a most taper. The first is cone angle or taper, the length of the conical surface, and the manufacturing tolerance. So for dentists, I don't have to make you understand about the taper because we are so much used to with all endodontic instruments. We know the 2% taper, 4% taper, 6% taper, and how to calculate the greater diameter, the minor diameter with the help of a length. We can easily calculate the taper. But for engineering point of view, the taper angle of most taper varies somewhat with size of the length of the conical connection, but it's typically around 1.49. For every metal, there is a specific taper. For example, titanium has 1.5 and steel has 1.2. So for dental point of view, we should understand that only 1.5 degree taper, because we are using the titanium, is recommended. The length of the cone is crucial. If it's very critical to have sufficient surface area for a friction fit. So imagine if you have 1.5 degree taper, but you don't have enough length of the cone, you cannot expect a more stable connection or friction fit which will hold the forces for a longer period of time. Also, the deep joints were more likely to resist bending forces than the shallow joints. Manufacturing tolerance. The material, machine tolerance, and quality of machine parts are very critical. So here, you have to have a very specific titanium alloy, which is, I suppose, is TI6Al4V, which has a greater rigidity in compared to other titanium, which can withstand this friction forces. Also, the precision of the manufacturing is to be very, very, very accurate. If your tools are not accurate or cone is not accurate, it's not going to give a secure joint with implant and abutment. Right? So based on this well-known engineering principle, the first implant which was introduced with locking taper was in 1985. It was so successful that the company has still continued the same design. So imagine if your patient has got an implant done in 1990 and he's still alive, or they want a different prosthesis, or you want to change the crown, or if you have got one tooth and now you have to go for a full arch, you can change the prosthesis with the abutment now because the design is same, the material is same. So it's past, it's present, and it's still available. The assembly is achieved by drawing 1.5-degree Morse taper into machine socket of the implant. A high clamping force being between the abutment and implant is generated by this action. So how does the assembly, like for the abutment implant, we have to fix the screw. Here we have to drive the abutment inside the implant valve, right? So if this is, say, I think this is not working. But if you suppose that if you have this part of the abutment which goes inside the valve of the implant, then you feel that the pressure should be from lower side and it will pop up the abutment out. But because of this high clamping force, the abutment will be held in position with these friction forces, right? So because of this friction force, surface oxide layer breaks down and aspirates fuses. So the implant valve and abutment cone, they have a friction fit, and because of this friction fit, the surface oxide layer of the titanium, because titanium cannot stay like titanium, oxide layer is always there. It gets damaged and it gets fused with one another. Therefore, gap between two surfaces almost disappear. Now, what I mean to say here, almost disappear because no parts, because they are different, they cannot be made same. So there is very little space between the abutment and implant where there is no possibility of having a biofilm. So the microorganism cannot grow or sustain over there, right? So which I mean to say over here, it's almost disappear. So here, suppose we have an abutment, an implant. Once we place the abutment, the clamping force will hold the abutment. The friction forces are so great that two mating tapers will not rotate or move with respect to one another.
Dr. Hemang, could you
So,
please be a little louder?
okay, you want me to be louder?
Yes,
Okay.
please.
So the friction forces are so great that two mating tapers will not rotate or move with respect to one another. So once they are not going to rotate, we don't need an anti-rotational indexing or structure or geometry to keep the abutment in place. And if it's not going to move, we don't expect micro motion in relation with one another. No clamping force are required to keep the parts joined, but considerable force is required to separate them. So once the abutment is fixed inside the implant valve, we don't need a screw, holding screw like prosthetic screw to hold the abutment into place, right? So the clamping force are enough to hold the abutment at its place. The friction joint design leaves minimum space between the fixture and abutment, which I already told. This is an extremely rigid and accurate method of joining. So here I want to say that almost we can say that two-piece implant becomes one-piece implant because now it is very rigid. It does not have micro motion and it does not have the space for biofilm. So there are many studies being conducted which proves that whenever there is a Morse taper connection and it is been properly fixed, then there will be no micro motion. And if there is no micro motion, there is no micro gap and they have a good or perfect bacterial safe. So to be, I'll just summarize again. The Morse taper should have 1.5-degree taper. It does not require the screw to hold the implant and abutment in place. It does not require anti-rotational geometry, and it does not leave any space for bacteria to grow. So now we come to our next part, which is self-releasing taper or STIP. So what are they? So anything which has a different angle other than 1.5, I have made a group of self-releasing taper. There is one another feature also in this because uh, it does not have that 1.5-degree taper. It needs an anti rotational geometry. And so what we see is it's a fusion of both the slip fit and the taper connection, which is called the self-releasing taper. So they are the smart new connections. A few systems may also call themselves as a hybrid connection, where they have a small initial taper and with internal connection systems such as internal octagonal or hexagonal, right? So over here they have uh, internal hexagonal or octagonal connection with small taper. Right? A conical portion in the screw down in the implant, it exerts pressure on the sides of the implant. Well, this create a friction fit with the implant. So the conical part will create a friction fit. The hexagonal or octagonal index will serve as an anti-rotational feature. The prosthetic screw will create a clamping effect. So what this system wants to tell that same way we have to engage the octagonal with the corresponding well or hexagonal with the corresponding well of the implant, and then we fix the screw. And while we fix the screw, the conical connection part of the abutment will push uh, uh, the surface or lateral surface of the implant, and doing so they will create a 360-degree seal around the abutment, right? So we can see that over here it is a good seal, while over here where there is a parallel connection, there is some micro gap. So how we differentiate this with our Morse taper? So we compare and contrast different features like whatever we have say for the Morse taper, like cone angle, length of the conical surface, tension of binding screw which was not over there, and manufacturing tolerance. So the cone angle. Here we had 1.5 degree for Morse taper. For here, any expulsive angle which will decrease the friction fit, because you can imagine that if it is like this, you have more friction fit, and if it is like this, you will definitely have less friction fit. Right? Length of conical surface. The reduction surface area of taper connection design decrease the friction fit. So if we have only this much area of internal connection, and half of it we have utilized it for the anti-rotational geometry, which has a passive fit, right? So we are left with only half portion left for the conical connection. So we have reduced the surface of conical connection in this. Third, the tension of binding screw. Uh, Here we are not dependent on the conical connection. So we need to apply a torque to fix the assembly with implant, right? So torque is required according to company's recommendation, and which will hold the abutment with the implant. We cannot hold the abutment to the implant without a screw, right? And anti-rotational is achieved by hexagonal, octagonal, or trichannel index. I don't know that any trichannel index is still available for hybrid, but it can be. Now, microspace. Due to the fact that locking device in a hexagonal or octagonal index allows parallel surface between the components of abutment male and implant female coupling, there are micro spaces between them. So, so that there are micro gap which will allow your geometry to fix on the implant connection. So the clearance fit between zero point 0.8 to 1 micron is created during non-axial loading of the implant at the parallel wall connection. So we can say that there is a clearance fit over here present, and above it we have a conical connection which has a seal this area. So the company which uh, tells us that we have a micro gap inside, but it has been sealed 360-degree on the top. So there is no chance of the bacteria to go in and out with this. But what happens when we chew or during the dynamic loading, the presence of micro gap will create micro movements, which will eventually break the seal formed by small conical connection. So with the movement, that conical connection seal will break, and we can bacteria can easily come in and come out from there. So there are certain uh, analysis done, and they have shown that within 5 minutes, the endotoxin can go in and come out from that connection part. So it is not totally safe, right? Conical connection or hybrid combines these two connection design also decrease the friction fit of the conical connection, which in turn lower the compressive strength according to some studies, which is quite obvious. So again, this is not a scientific photograph, but I just wanted to make you understand that if we have three same length implant with same length of internal connection, right? What are the difference in it? So the first one is a slip fit or passive fit implants, where we can see the yellow line, which shows that there is some micro gap throughout the length of the connection. In this conical connection, or we can say self-releasing part or C type, where we can see the micro gap only at the place where there is a parallel one. The conical connection has little bit less space, and most taper connection has minimum space. Right? So now we come to the main part. So what the micro gap is going to trouble us? How it is biologically and mechanically important for us? So there are many methods to which they have checked this micro gap, like fluid penetration, bacterial penetration, scanning electron microscope, molecular leakage, and they have come to conclusion that almost all implants, maybe slip fit or conical, they have found that they have micro gap between 1 to 49 microns. And why it is important? So the size of bacteria is zero point 0.5 to 2 microns, right? All bacteria come under this size. So the average size of my bacteria is zero point 0.5 to 1.5 in width and 1 to 10 in length, depending on the shape of the bacteria. Right? So I just, even this is not a scientific photograph, just to make you understand that this part between implant and abutment, the bacteria can easily go in and out at different sizes. Right? This is a photograph showing a failed implant where there is a colony of bacteria at the junction of implant and abutment. Right? So during dynamic loading or during chewing, the micro gap increased because of micro movement. The size of micro motion is from 1.5 microns to 94 microns according to some studies. 94 microns is huge gap. We can say that almost the bacteria can flourish in this space. So what I like to show, as we have commercial break, we are going to have a non-commercial break over here. I call it non-commercial break, like in your movies and webinars, or sorry, web series. Like here, it's not commercial. We have this scientist Ziprick has shown and ripped off all the implants company, and they've shown that there is a micro space between the implant and the patient. You can see these videos on YouTube, but I like to play for you. Right?
Inside of the 5 mm implant, and if we have, there is a micro gap, and also there's a micro gap before, so the and also at the enlarged bicon system, we can see below cheap copy of a bicon system, and we can see there is a micro gap inside of the here to the conical interface.
The name of the company.
You will see that there is such a high contrast in comparison
designs and
inside of the conical interpermanent shift. And we also can see that it starts at only 100 newtons. Interface moves sideways, and the micro gap we will see is in an area of 36 microns. And now think about when.
So with dynamic loading, we'll come to this point again. Yeah. So what we can conclude from this video that almost all the implant abutment connection has some space between them, micro gap. The slip fit design has maximum, the conical has less, and most taper has minimum. Most taper comes in the green zone because we don't have a space for biofilm to grow. The conical has little bit resistance towards that, and slip fit has least resistance to that. Right. So we'll come to the biological complication. No, as we know, our oral environment is full of microbes. Some are pathogenic and some are protective. And So what normally our doctors, they say when we open the healing cap, we put abutment, we expose the implant surface and well, each time we take a trial. So the bacteria, we cannot control the bacteria to go in and out. So what the studies has to say that microorganism colonizing the outer surface can be eliminated by the host defense mechanism. However, the microorganisms that are internally colonized the implant and the surface in like implant abutment surface can persist for a longer period of time, right? So you cannot get rid of it. The implant well acts as an ideal place for bacterial proliferation and fluid microleakage, right? So even the screws which we use, they can be like a carrier for the bacteria. During mastication, the cyclic opening and closing of microgap will exert a pumping effect on liquid containing the implant, causing zone of toxicity at the level of microgap. So, as we have seen in that video, as the implant and abutment moves, there is a cyclic opening and closing of the microgap. So there is a pumping effect to the liquid. We can also call it as a micro pump, right? Endotoxins of bacterial origin will in turn contaminate the crestal bone, which causes resorption. The extent of resorption is limited to the radius of contaminated tissue. Now, this is very important. Then, how can we say that resorption, which is occurring around implant abutment junction, is mainly because of this? And then, this is a study where you can say the radius of the resorption is confined to the endotoxin which has penetrated over there, right? So alveolar bone will then remodel to below the zone of toxicity and typically towards the first thread of the implant. So till now, most of the companies or researchers and everybody says that if you have 1.5 or 1.8 mm of bone loss after loading, it's totally fine. And zero point 0.02 or zero point 0.2 is after every year, it should be okay. The endotoxic liquid is also responsible for unpleasant odor, taste, infection of the tissue damage. Right? So here I just made a small graph or chart. So the microgap will create micro motions, micro pump where the bacteria can grow, and with the micro motion, you can sometimes make a micro gap into a macro gap and add more bacteria, which in turn will infect and inflame soft and hard surrounding tissue and causes periimplantitis. So now we come to the next section, which is mechanical complications. Now, as I have briefly told you about the biological complication, even the mechanical complication is self-explanatory, but I'll just go through it. This mechanical movement causes the material to undergo fretting and material wear due to small amplitude oscillatory motions, right? Because of wear and tear, it's like rubbing of abutment surface and the implant surface during the micro motion. So enlarge micro gap and subsequently increase the micro motion. The mechanical problem related to micro motions are like elastic deformation of the implant, screw loosening, screw fracture due to fatigue of the screw retained abutment, abutment fracture, implant fracture. This abutment fracture, implant fracture might, because sometimes the abutment implant are not fitting well, they create a different pressure altogether, and which might lead to failure of the abutment or implants. Very rare. Other complication are there are some studies which shows that material wear also causes abrasion of the titanium surface, leaving small particles of titanium. So as I told you, there is a friction between the abutment and implant or rubbing of the abutment implant, which causes abrasion of the two metals. Now, we as a clinician, normally we don't think so much about it, but abrasion which has a particle size of 100 microns, and our body will try to absorb that, right? And it induces a cellular response to it, which might also cause some systemic problems later on. We don't know, but it might cause a systemic problem, right? So again, I just made a small chart which explain you the mechanical problem, the micro gap, micro motion, screw loosening, screw fracture. Whenever there is more, movement between the abutment and implant, the screw loses tensile strength, and there are chances of fracture or loosening, the abutment fracture, implant fracture, right? So now we come to the clinical application. We have quickly come to the end part of our presentation. I hope it's not so boring. So even here, most of the things are self-explanatory, but just I want to give you some brief knowledge about how this implant abutment connection will influence our treatment. So I'd like to share this photograph, which was viral in almost all implant groups, and it might be, available to you also, where they have advocated this placement of implant in different uh, situations. So again, I have tried it to simplify it. Implant position in apical coronal level related to gingival biotype. I should not use this gingival word. I can use this soft tissue because gingival is for the teeth, but it's okay. So this category in the first row is where we have only 1 mm of soft tissue, where the crestal should not be done. Crestal placement of the implant should not be done. But 1 mm of subcrestal should not be done. It should be at least 2 mm of subcrestal, right? Similarly, if you have soft tissue of 2 mm thickness, you should not place at the crestal level. You can place sometime 1 mm deep, or you can place 2 mm deep. If you are lucky to have soft tissue of 3 mm, you can place on the crestal level or 1 mm below the sub crestal level or 2 mm subcrestal. So this makes things little simplified and as easy to understand. So the criteria is most of the implant which we have to place is should be subcrestal, right? So imagine if we have placed our implant. This is my X-ray, old X-ray, where the implant is being placed, which are normally placed around 2 to 3 mm. I go a little deeper most of the time to place the implant, and we put our abutment and the crown on it. So if the implant abutment connection is aseptic, so there is no micro movement, we can expect this bone to stay over here for longer period of time and it will not go away. But if we have a connection, as we have learned that the connection might have some bacterial infection. So what is going to happen? So I just done few drawings for you to understand. So this is the initial where we have gone at least 1.5 to 2 mm subcrestal, right? The implant has properly osteointegrated and is trying to have a second stage surgery where we put an abutment and crown without it's an uneventful situation, right? So this looks perfectly well. Now what happens after a few months of time that the bone level will start dissolving if the implant abutment connection is not proper, right? And after few months or years, it will settle to first thread of the implant, like like the socialization loss or resorption, we can say um, in area of implant and abutment connection. So this is if this is going to happen, there is no meaning of placing our implant subcrestal because eventually, if you are going to lose this bone, then there is no meaning of placing it subcrestal, right? So, what are other problems when we place it subcrestal? The profession, implant maintenance, and meticulous patient home care are important factors. But because the location of peri-implant surfaces are subgingival, patients and clinicians have limited control over hygiene measures to prevent infection. Because the microgaps at the implant abutment junction are non-feasible, the dental implant may pose risk to systemic health also. So there are many conditions where there is always infection in relation soft tissue infection, peri-implantitis in relation with this connection, which we cannot clean or we cannot maintain properly. So this problem might happen if we always place our connection subcrestally, right? So now all of the world is looking at a different direction. But if we can think about if our connection are uh, through bacterial seal, we can also expect bacterial bone growth over the implant abutment connection. Now, this is little controversial subject. We'll not talk so much about it, but it's just to give you some brief introduction about bone creeping. So most of the people right now are talking about how to avoid bone loss and whether the first spread is okay or not. But there are certain studies and things which can help for bone creeping or bone gain for the implant abutment connection. Right. So implant abutment and hard and soft tissue are all related with each other. Now, to end, we'll just come to a conclusion. Two-piece implant system consists of implant abutment and are widely used situation. The advantage over one-piece implant is that it allows implant to be unloaded during the bone healing phase and provides benefit to adjust the prosthetic angle depending on the abutment selection for the placement of implant. A disadvantage of two-piece implant, as we know that there are more micro gaps and at the implant abutment connection. So implant abutment connection is a component responsible for transmitting oxygen load from the processes down to the implant. And according to the shape, geometry, and structure of process structure, we can see the force distribution on the implant, different connection. So, right. So we have to very meticulously use this connection and think about our implant design accordingly. Not every taper connection offers real Morse taper mechanical locking. So again, I'll just brief you about the Morse taper. It has to be a 1.5-degree taper connection. The cone length should be proper, right? And there is no need of anti-rotational geometry. There are few implant companies which I know which has anti-rotational geometry, but they have kept for the alignment of abutment to the implant. There is no role of anti-rotational hexagonal or octagonal design in their implant system. They have also a screw to assist the abutment to fix on this implant. So some people don't like to tap the abutment on the implant, so they have come with a noble way of putting abutment to the implant with the connecting screw, which will just allow the abutment to place on the implant. And if you remove this screw, the assembly is going to be like that only. So there is no active role or clamping features of that screw, prosthetic screw in most taper connection. Right? What affects the joint is the precision of manufacturing, the stability between mating parts, and use of adequate torques so that parts stay fitted together. So here I like to advocate that whatever company you are using, you should make sure that you use the same company parts, because the precision with the same parts will be more than the different companies or customized part. What what will be the biological response to the process you gave to the patient? So this question you have to ask when you select your implant. So what will the biological response when you place implants in your patient? Whether it's going to have some infection or it's a bacterial seal, right? So the preventing system-based complications. Now, if we rule out every other problems, we are just focusing on the system-based complications, right? So to conclude, our choice of implant really matters, which has good connection, right? The, and I will just end this last slide. The presentation does not advocate one connection design over another, rather clears the confusion regarding different implant abutment connection currently available in the market. So I don't endorse any company, so please don't ask questions about how much degree my implant has the taper connection, or whether this type of most of you might be you have to exclude if your company has 1.5-degree taper. It's a Morse taper connection. If it doesn't, it's a normal conical connection, right? So you can ask question only regarding this implant abutment connection, and we'll precisely end our topic presentation over here. Ruben, can you hear me?
Thank you, doctor. Thank you very much for the lovely session. I'd request you to kindly stop your screen share. Friends, you have about 2 minutes to post your questions. In the meanwhile, I would like to take you through our upcoming webinar. Our upcoming webinar would be held tomorrow, It would be on the topic questions answered on digital dentures, scan, design, print, mill. The speaker for which is Dr. Karthik Bhanushali. He's a prosthodontist based in Mumbai. We would love to have each and every one of you attending this webinar. You can see the registration link in the chat box. I repeat, you can see the registration link in the chat box. All right, friends, if you're ready, we will start with the live question and answer session. Doctor, can we start? All right, here goes the first question. Question from Dr. Aradhya. When Morse taper is a better fit rather than the slip fit, then why is slip fit used more?
You know, for making a Morse taper connection, the companies has to be very precise. As I told, there is high engineering work required to make Morse taper connection. So most of the companies are not making this, and I suppose there are some patented versions also. So they might be restricting other companies to copy their designs.
Thank you very much, sir. Moving to the next question. Question from Dr. Bhumi. Question from Dr. Bhumi is, can we say that Morse taper has almost zero micro gap? If no, then is there any way we can achieve zero micro gap?
See, the study says that most taper has zero point 0.5 microgap. So zero point 0.5, and we have seen that most of the bacteria uh, are more than 1 microns in size. So we can say that it's a zero bacterial contamination area, or there will be no microfilm, biofilm on that. So we can say that it's no microspace. The only Morse taper right now connection offers this. We don't see any other connection which has bacterial seal right now.
Thank you, sir. Moving to the next question. Question from Dr.
Can you be a
Simran.
little louder? I cannot hear you properly. Sorry.
Sure, sir. Am I audible now?
A little better, yeah.
Okay. Next question. Question from Dr. Simran. Can Morse taper design and platform switching, when combined, will have less peri-implant implications?
Surely. Most taper connection, the design is of itself like that almost all abutment coming out of it will have a platform switching design. So you have both advantage. First of all, we can say that there is bacterial seal, so we are not actually concerned about the fluids coming out with the pumping action from the sides of the implant abutment connection. But platform switch is always there, and which will help in increasing the biological width around the implant. So it will help in another way rather than the bacterial infection.
Thank you, sir. Moving to the next question. What are the limitations of Morse taper connection?
Yes, very important to know. The limitations is it's very difficult to remove the abutment and place it back, right? So the newer companies are coming with different options with the removal tool, or if you don't have the removal tool, you have to torque the abutment and then gently tap the abutment, right? And you have to be very careful while placing implant also, sorry, and placing abutment also. If you damage the implant wall during placement of implant, you lose your implant forever, because in no way you can achieve the Morse taper connection back. Similarly, if you damage little bit of your abutment connection, then you have chance to use a new abutment in that place. So this is very important to know before using this connection. Yeah.
Thank you, sir. Moving to the next question. Question from Dr. Kumar. Could Metrox gel application over IAC provide any benefit in avoiding any bacterial infection and make it up for the micro gap in IAC, in the implant abutment connection?
Correct. So there are certain sealing gels also available, which company claims that they can reduce the bacterial growth instead of micro. They have certain contents which can hold the antimicrobial activity for a longer period of time. Uh, this is like the damage control. We are trying to put an implant first, which has a bacterial contamination problem, and then we put a sealing material which will decrease this. So yeah, this might help you to decrease the microbial count, but there are no specific studies which advocate this.
Thank you, sir. Moving to the next question. Question from Dr. Vivek Raj. What should we do if implant protruding the sinus in upper jaw?
Okay, I didn't get the question. Means implant is protruding in the sinus
In upper jaw.
in upper
That
jaw.
is the
Okay,
question. Yes.
so maybe he's asking about the perforation done by the implant, and this is little off track question, but I would like to answer that if you have done a sinus lift and you're not tear the membrane, it will take care of that. It's okay.
Thank you, sir. Moving to the next question. Question from Dr. Azher. What is the protocol for submerged implants and implants placed at crest?
See, as I told you, if a connection, if you're confident about your connection, and that is going to give a good bacterial seal, then you should always think about placing it subcrestal. Now, as I showed that slide, which has been viral, the photograph was viral last few months, and almost all the companies, all clinicians, they suggest to put the implant subcrestal because if you have some bone loss, they will take care. But if a connection is not good enough, your bone loss will continue till the first thread of the implant. And if your biotype, gingival biotype, we have seen in Indian patient more so you don't get enough thickness of gingiva where we always suggest to have a good subcrestal implant placement. We can say that good, and that's for a crystal implant placement. Right?
Yes, sir. Thank you. Moving to the next question. Question from Dr. Urvi. How can we reduce micro gap in slip fit?
So it's nowhere in the hand of clinician. We don't have any control over this, so it's out of our control. You have to deal with this.
Thank you, sir. Moving to the next question. Can we use one piece implant compared to two-piece implant so that we can overcome micro gap?
Yes, definitely. One piece implant, as you know that it's does not have any gap between it. So one piece implant has better, but we cannot unload one piece implant. Uh, Even I was a good user of one piece implant, and I really like that implant. And you don't have much correction in the prosthetic part, and you have limitations of the prosthetic connection also. So. The two-piece implants are more right now in the market.
Thank you, sir. Moving to the next question. Question from Dr. Kaushik. Which is the most important test to detect micro gap? How much does it cost?
See, according to as a clinician, I can say that if you remove the healing abutment or abutment, if you have a foul smell, right? This is one of the most important, thing which suggests that there is a micro gap which is causing problem, right? Other than that, you can take swab, you can check with the laboratory person, and you can. But it's not easy to control. If when you take a swab, we know that our oral cavity is flooded with microorganisms. So how we have got a good swab from the abutment, so it's not possible for us to check in the patient mouth except this order or the other way we can see check with the x-rays, inflammation and all that things, the clinical signs and symptoms, whether there is infection around implant abutment connection or not.
Thank you, sir. Moving on to the next question. Is there a failure rate in short implants?
Yeah, the short implants, yeah, it's my favorite topic, and it's so failure rate is similar to the long implants, but you have to be have a good protocol for using the short implants, which place where the connection over here is very important because if I'm using a 5 implant, suppose, and if I have 1 bone loss, right? So I'll be left with 4 mm. So almost 25% of my bone, the implant surface I have lost. So I have to be very precise with the connection. I use this spectral seal connection for short implants, and in no other implants I'm using for the short implants.
Thank you, sir. Moving to the next question. Question from Dr. Poonam. Do high polished implant connections decrease bacterial colonization?
Yeah, the high polish color, like tissue level implants, uh, definitely they will discourage the bacterial growth over there, and it's again like to control the damage done by the connection. But they have very limited implication. You cannot use in the anterior place where the polish color can expose and you will get the metal surface will be visible. And if you are placing it on the posterior region, or you have to be very near to the CEJ of the adjacent tooth to have a good emergent profile. And so there are certain limitations of using this tissue connect implant, the polish color implants. Yeah.
Thank you, sir. Moving to the next question. Question from Dr. Supriya. Anything can be done to reduce the screw loosening as in the tip?
Yes, as I told you, uh, first of all, you have to fix your screw with a hand ratchet, or sorry, hex. Check everything before tightening. We'll check the x-ray. You are confirmed that the abutment is being properly fixed at your position. You don't want to do any changes. That x-ray looks perfectly well. Then you need to torque once according to company's recommendation. And you have to be a very clean surface when the screws and everything is available. Now over here, what I do is when I give my work for the prosthetic work to the laboratory, I have kept different screws for them. For the prosthetic fitting, I use a new screw for that purpose. For any other purpose, I use that screw for trial, and for laboratory purpose, I use that screw which I am using it for multiple purposes. I just clean, sterilize, autoclave, and then reuse. So this is a very good tip, and it will prevent further problems to you.
Thank you, sir. Moving on to the next question. Yeah, moving on to the next question. Question from Dr. Ravan. What is the oxide layer complication with implants?
With implants,
Yes, sir.
see, here we are talking about implant abutment connection, but we are not talking about the oxide level of the implant. Now, normally what happens is, implant has to be the titanium surface, which is titanium oxide. So if there is any disturbance in that, it will not, the blood will not touch the implant surface, and it will not start a good integration with the bone. But this is a little different, and there are so many different thoughts about it. So it's all towards the biology part of the implant and the bone complications.
Thank you, sir. Moving to the next question. The mostly used implant connection in the world is the 1.5 Morse taper connection. Then why is it that clinicians are using different implant systems?
Yeah, first of all, 1.5-degree connection is not mostly used. It is very limited use. I should say that where there are very limited persons or clinicians which are using this. Again, it is little expensive in compared to other implants, so it's less popular. Uh, the system, as I told you, you have to be very precise in placing the implant. You don't have to damage the implant well. You have to. It's not so user friendly. Means it's user friendly, but you have to be cautious about using this implant abutment connection. But as I told you, it's been used since 1985. It's still using, and it will be future, because most company will eventually move towards 1.5-degree taper to give you good bacterial seal.
Thank you, sir. Next question. Dr. Akshay. Since many implant companies claim that there is a no bone loss concept in implantology and are stressing in the implant abutment connection, what is your point of view in this subject?
Yeah, again, this is little controversial that they have say that there is no bone loss, but when you try in your patients, what results you are getting? So it's a control group which says there is no bone loss, where in the practical point of view, you have a different scenario. So it depends from this to that. But if you believe in implant abutment connections microgap, you can easily think that if there is a microgap, there will be bone loss. There is no way you can stop this bone loss in vicinity of this implant abutment connection.
Thank you, sir. Moving to the next question. Can we increase better bone remodeling using Morse taper connection?
Yeah, the last slide which I showed was a patient coming after, say, 13 or 14 years, and you can see the bone creeping around the implant. So if the forces are favorable or ever around the implant abutment connection, we can expect bone growth over there. But still, as I'm telling you, there are control studies and control group where you can expect bone remodeling and bone growth in around an implant abutment connection.
Thank you, sir. Moving to the next question. Since Morse taper is almost parallel to the implant well, how are you able to take out the abutment in case of restoration or breakage?
Yeah. So you have to hold the abutment parallel to the implant well. So if you are holding this, right, if you're holding the abutment and then you try to give a jerk in the same direction, right? If you tilt little bit here and there, again you are going to damage the well. The second technique is you torque and pull it out, right? The other method is like, the new companies are coming, they have a special tool for removing the abutment. So you put the abutment retriever, you put, and you just give a small 2 or 3 hex movement, and it will pop out.
Thank you, sir. Next question. Do you conduct courses on short implants? If yes, do you conduct them in India?
You can email me regarding this, and we can yeah, surely let you know whenever there is something happening in this. As of now, we don't have any course for next 2 3 months.
Thank you, sir. With this, we come to an end of the live interactive question and answer session. Thank you once again on behalf of Team DentistChannel.Online to Dr. Hemang for the lovely webinar and to all the participants for attending this webinar. Friends, a certificate of participation will be issued to you within 3 working days. I repeat, a certificate of participation will be issued to you within 3 working days. Please do register for all the upcoming webinars. You can follow Dr. Hemang on his social profile. You can follow us on the social profiles. Thank you very much, Dr. Hemang. Goodbye
Thank
and
you
have a
so
good
much,
day.
and everybody, please be prepared for reopening your clinics. Bye.
Thank you very much, sir. Thank you.